Hello everyone, my name is Dr. Santosh Mairal. I'm a third year resident at the Department of Radiology at DRC Hospital. My paper is on MR imaging of rotator cuff tear, what to report, and how it is clinically and surgically relevant to the surgeon. Learning objectives of today's presentation is understanding the radial anatomy of rotator cuff, how to describe the rotator cuff tear on MR images, its reporting and significance on management and outcomes. To start off, we will briefly revise the relevant anatomy of rotator cuff tendon on PD PATSAT images seen below. The rotator cuff is complex functional unit with multiple tendons and their insertion at the humeral head with blending of fibers of adjacent tendons with each other. As we see on sagittal image, from anterior to posterior, the tendons are seen over the humeral head in clockwise direction as subscapularis, supraspinatus, infraspinatus, and teres minor. The posterior tendons, supraspinatus, infraspinatus, and teres minor, have their attachment on the greater tuberosity, and the anterior tendon subscapularis has its attachment on lesser tuberosity, bicipital groove, and few of its fiber cross over the bicipital groove to attach on the greater tuberosity. The supraspinatus tendons has anterior fibers and posterior fibers, as seen on the axial image, which in itself has three layers: the superficial, middle, and deep, from bursal surface to the articular surface, as seen on the oblique coronal image. The subscapularis muscle craniocaudally has separate attachment of upper two-third and lower one-third fiber, as seen on the oblique coronal image. The following image shows us the recent classification as given by the International Society of Arthroscopy, Knee Surgery and Orthopedic Sport Medicine, which shows us a relevant information and what orthopedic surgeon want from the report. So the rotator cuff tear on MR can be broadly assessed by the location where it is posterior superior involving the supraspinatus and infraspinatus tendon and anterior involving the subscapularis tendon. The supraspinatus tendon is most commonly involved tendon in rotator cuff tear with or without involvement of adjacent tendon or structure. Its tear can be classified into partial thickness and full thickness tear. The partial thickness tear, according to the pattern, are reported as articular, um, bursal, and interstitial. According to the extension of the involvement, uh, we have we gave it as high grade or low grade tear. We will come to analyze the partial thickness tear of supraspinatus tendon on oblique coronal PD PATSAT images. In figure 1A, we see fluid intensity along the fibers of the supraspinatus in contact with the humeral head, that is the articular surface, suggestive of a articular sided partial thickness tear. These are most frequent types of tear. Management of the tear depends on the grade or extent of the tear, which we will see in the upcoming slide. Figure 1B shows involvement of the fiber close to the bursal site. These are more painful and do not show spontaneous healing. So surgery is seen as the mainstay of treatment for these tests. Next image shows intact fibers along the bursal and the articular surface, but there is fluid signal intensity seen in the interstitium of the tendon, suggestive of the interstitial tear. These are most painful and often hidden at arthroscopy, so can be missed by surgeons. Hence, reporting them on MR report is essential on the part of radiologists. MR has high sensitivity and demonstrate the bursal and the intertendinous tear. Next, according to the percentage of involvement of the thickness of tendon, they are classified as high or low grade. In the first image, we can see the involvement of bursal fiber with more than 50% fibers involved, which is suggestive of a high grade tear. Uh, these are these tear are to be managed actively as they have tendency to progress to full thickness tear. These tear occurring in the overhead athletes are preferably managed conservatively unless the tear is more than 75% of thickness, as operating them can lead to stiffness of the joint. In rest of the patient's mainstay of treatment is surgery. Figure 2B shows a tear with less than 50% involvement, suggestive of a low-grade tear, which is managed conservatively. If no response is seen, then the surgery can be considered. Next, we have full thickness tear, in which we mention the pattern, the anterior posterior extension, and retraction of the tendon. Full thickness tear is seen involving both the articular and the bursal side of the tendon. It is important to note that full thickness tear does not imply the involvement of entire anteroposterior diameter of tendon. These tears do not have self-healing ability and progress to altering the shoulder kinematics and eventually changes of osteoarthritis. According to the pattern of the tear, they are classified as crescent-shaped, U-shaped, and L-shaped, as seen in the following MR images. Recognizing this pattern is essential for surgeon, as we can see in the figure 3D, the different approach to surgical management taken in different patterns of tear. Extension of the tear along the anteroposterior length of the tendon is to be noted. A supraspinatus tendon tear may extend anteriorly to involve the medial aspect of the coracohumeral ligament and superior subscapularis tendon fibers, associated with more severe supraspinatus atrophy and poorer prognosis. Reporting it on MR image is important because subscapularis tendon is hard to visualize in a standard surgical approach to rotator cuff repair, hence may go unrecognized during surgery, resulting in unsuccessful outcome. The retraction of the tendon is to be mentioned as it is essential for surgical planning. It predicts the mean surgical time and amount of soft tissue release that would be necessary to repair of deeper retraction. There are three grades. The grade 1 tear with minimal retraction, grade 2 fibers retracted over the humeral head, and grade 3 fibers retracted up to the superior glenoid margin or more proximal to it. As you can see, greater the retraction, the worse is the prognosis. Talking about the anterior location, that is involvement of the subscapularis tendon, these tears are difficult to recognize on MR image and arthroscopy. Degenerative tears are most frequent. They begin in the upper third and progress caudally. For grade 1 tear, as seen on figure 1A, figure A and B, small amount of fluid is a useful sign. Large tail of subscapularis show retraction of bone tendon with associated subluxation of the bicep tendon as seen in the figure C. Uh, it can also involve adjacent anterior fiber of supraspinatus muscle as seen in the figure E. Grade of subscapularis tear is given by Lafosse. Grade 1 in which there is partial thickness tear of upper third of the articular surface only. Full thickness, grade 2 is full thickness involvement of with complete detachment of the upper third. Grade 3 is upper and middle third is involved. Grade 4, full thickness tear of tendon of subscapularis without subluxation of humeral head and fatty atrophy. Grade 5 is grade 4 plus anterior subluxation of the humeral head. Depending on the grade, the management is decided. Next, we have to mention the fatty atrophy, fatty infiltration, and atrophy of the rotator cuff, as it is a major prognostic factor for the structural and functional outcome of rotator cuff surgery. It is associated with a higher rate of re-tear. Fatty infiltration, as we can see, is given by Gottlieb classification, and atrophy is we assess by tangent sign. Take-home points for our rotator cuff tears are common cause of pain and disability. They are variable in location, tear pattern, and functional impairment and repairability. The points to be mentioned in the report are location of the tear, the dimensions of the tear, tear morphological feature, extent, retraction, involvement of contiguous structure, muscle atrophy, and fatty infiltration. MR can depict almost all of the various features of rotator cuff tear. Radiologists should be familiar with the radiological appearance of different rotator cuff tear and the reporting pattern, thus helping the surgeon to make appropriate course of action. Thank you.